Welcome back, coders and healthcare professionals. Today we're diving into an area of medical coding that honestly trips up a lot of folks, but it is absolutely vital to get right: nursing facility services. We're talking specifically about CPT codes 99304 through 99316. In this explainer, we're going to walk step by step through the entire patient journey, breaking down the exact rules for initial, subsequent, and discharge care so you can code with absolute confidence. Okay, let's dive into this.
Here is our agenda for today. 1. The nursing facility landscape. 2. Initial facility care. 3. Subsequent facility care. 4. Managing facility discharges. And 5. Special rules and transitions. Section 1. The nursing facility landscape.
So what exactly counts as a nursing facility setting? Well, the CPT guidelines use this as an umbrella term that groups together a few specific environments. We're talking about skilled nursing facilities. You'll hear those called SNFs, standard nursing facilities, psychiatric residential treatment centers, and intermediate care facilities. Basically, if your provider is treating a patient in any of these physical spots, this is exactly the code family you need to be looking at.
Now here's a detail I absolutely love because it genuinely makes our lives easier as coders. You know how in the clinic or the office you're constantly having to ask, wait, is this a new patient or an established patient? Well, you can toss that right out the window here. Both new and established patients use the exact same code subcategories. It brilliantly illustrates a unique quirk in nursing facility billing. You literally don't need to stress over the 3-year new patient rule to pick your code. The set is totally universal for the setting.
Section 2. Initial facility care.
Looking at the official CPT guidelines for initial nursing facility care, that's codes 99304 through 99306, this is really the bedrock of the patient's admission. This is where the very first encounter gets documented, where the overarching care plan is born, and where the heavy lifting of medical decision-making actually begins for the stay.
But here's the million-dollar question. Who actually gets to build these initial codes? This is a huge area of confusion. We've got the principal, or admitting physician, who's overseeing the patient's overall medical care. But what if a specialist, like a cardiologist, comes in for a consultation? Well, believe it or not, consulting specialists also use these exact same initial care codes for their very first face-to-face encounter with the patient during that stay. You don't use outpatient consultation codes here. Everyone uses the initial nursing facility codes for their first visit.
But wait, there is a massive regulatory stop sign we need to talk about regarding the admitting provider. So the crucial point is this. In a skilled nursing facility, the initial comprehensive visit must be performed by a physician, period. I know advanced practice nurses and PAs do incredible, vital work in these facilities, but legally, that overarching initial comprehensive assessment in a SNF level of care has to be done by the physician.
Okay, let's break down the actual codes. The beauty here is you can cleanly choose your code based on either medical decision-making, MDM, or total time, whichever benefits the encounter more. Notice the escalation here. Code 99304 is for straightforward or low MDM, or 25 minutes. 99305 steps up to moderate MDM, or 35 minutes. And to hit the highest level, 99306, you have to reach high MDM, or a full 50 minutes of time.
I really want to spotlight that 50-minute mark. 50 minutes is your vital anchor point for billing a 99306 based purely on time. If your provider is in there spending 50 minutes coordinating a highly complex admission, poring over a mountain of data, and counseling the family, boom, you've hit that top tier.
Section 3. Subsequent facility care.
Now we're looking at the official CPT codes for subsequent nursing facility care, spanning from 99307 to 99301. Honestly, this is the bread and butter of facility billing. These are your daily rounding codes. You use them for everything from just doing a quick check-in on a stable patient, all the way to managing a severe acute flare-up of a chronic illness right there in the facility.
Let's move to and see how this builds across the subsequent care matrix. We start at 99307 for 10 minutes. Then 99308 requires 20 minutes. 99309 takes 30. And finally, 99310 requires 45 minutes or high medical decision-making. Notice how smoothly these thresholds escalate as the patient's complexity goes up.
Section 4. Managing facility discharges.
Billing at discharge isn't just about waving goodbye as the patient leaves. The CPT guidelines outline a very specific, all-encompassing workflow. Step 1 is the final examination of the patient. Step 2 involves a detailed discussion about the facility stay. providing continuing care instructions to caregivers, and getting discharge records and prescriptions ready. And step 3 is the actual billing, which has a massive rule you can't ignore. Code selection for discharge is based entirely on total face-to-face time on the date of the encounter.
Let me repeat that, because it is a total game changer. You cannot use MDM for discharge codes. No way. It is purely a time-based selection. You only have 2 codes to pick from. 99315 is used when total time is 30 minutes or less. But if the provider spends more than 30 minutes on that final discharge management, you bump up to 99316.
So 30 is your magic dividing line here. If an auditor comes along and sees a 993-116, the very first thing they are going to hunt for is documentation proving that more than 30 minutes of face-to-face discharge management actually occurred. If that time isn't explicitly documented, actually scratch that. If it isn't perfectly crystal clear in the notes, the code gets downcoded. It's just that simple.
Section 5. Special Rules and Transitions.
Okay, here is an incredibly common pitfall that I see costing practices so much money in denials. Imagine a patient is in an SNF receiving intensive rehab, and they step down to a standard NF level of care, but they stay in the exact same physical building. Can you bill a shiny new initial admission code? Nope, absolutely not. The rule firmly states that transitions between SNF and NF levels of care do not constitute a new stay. You just continue using your subsequent care codes.
And what happens when a provider just goes above and beyond? If your provider's time significantly blows past the 50 minutes for a 99306 or the 45 minutes for a 99310, you definitely don't want to lose that revenue. You capture it using the prolonged services code CPT 99418. For example, if you hit 65 minutes on an initial visit, you'd bill the 99306 plus the 99418 add-on code to accurately reflect the massive amount of time dedicated to that patient.
Well, we've walked through the entire patient journey today, from admission straight through to discharge. So I want to leave you with a question to chew on. How will you adapt your workflow to seamlessly choose between medical decision-making and time in your very next audit? Getting comfortable with both methods ensures you are always capturing the true complexity of the work being done in these facilities. Use this explainer as your roadmap, reference those time thresholds, and keep your documentation pristine. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.